This webcast and any accompanying materials are display, sale, copy, or distribution of the video or materials may only be undertaken with the prior written consent of the AARC. Copyright 2021, all rights reserved. My name is Lanny Nabnett, Vice President of Education and Meetings at the AARC. Welcome to today's program, Prevention and Treatment of Medical Device-Related Hospital-Acquired Pressure Injuries.
This webcast is sponsored by an unrestricted educational grant from Mallinckrodt Pharmaceuticals.
Upon completion of the AARC webcast, participants will be able to discuss the background around hospital-acquired conditions and pressure injuries, describe what the literature says related to the prevention and treatment of device-related hospital-acquired pressure injuries, provide an example of a large-scale performance improvement project between RTs and nurses to reduce the risk associated with device-related pressure injuries. I am very pleased to welcome Kevin McQueen. Kevin, a fellow of the AARC, is a System Lead Director of Respiratory Care and Regional Director of the Sleep Diagnostics, Wound Care, Hyperbaric and Diabetic Clinic at University of Colorado Health. Kevin also serves as the President of the Colorado Society for Respiratory Care. Mr. McQueen has no relations to disclose. I disclose that I am a paid employee of the AARC. Brand names of products and/or medications may be mentioned only as examples of technology. Any use of brand names is not in any way meant to be an endorsement of a specific product, but to merely illustrate a point of emphasis and to provide information and education regarding the availability. Kevin, welcome to the program.
Hello, and I want to thank everyone for attending. I know how busy everyone is literally across the country and around the world with dealing with COVID. Every one of us is probably beyond stretched and stressed and fatigued. So I really appreciate you taking the time out of your busy schedule to listen in and talk about what I believe is an extremely important topic, and that's about medical device-related pressure injuries that are acquiring within the hospitals. So the first thing I want to say to everyone is any information that I'm showing you when it comes to statistical data is that this information was brought to me or I put together prior to COVID. COVID has exacerbated the situation. So across the nation, we are seeing a higher incident of medical device-related pressure injuries. So really talking about this topic and discussing what we all can do together to reduce the risk or reduce the number of them occurring is really essential. So again, I thank you so much for coming. I think in the end, there'll be some information that will be useful, and hopefully when we get to the questions and answers, if anyone has any wonderful ideas they want to share, it's a great time. I'm always willing to learn from anyone that's had success in this area. So what's the situation we're looking at? Well, the Agency for Healthcare Research and Quality, the AHRQ, reported back at the end of about 2018, they looked at avoidable patient harm that was occurring in the hospitals between the years 2014 and 2017. And what they had found is that every hospital-acquired condition has seen a solid or steady decrease, and that included CAUTIs, CLEBSIs, adverse drug events, OB events, C. diff, falls, ventilator-associated conditions, and VE thrombosis. So the one area that we did not see improvement has been in hospital-acquired pressure injuries, or HAPIs, which sadly has seen an increase of about 6% during that same time frame. And right now during COVID outbursts, we're seeing much larger numbers are occurring at hospitals. And it's because staff is stretched so thin and these patients are so acutely ill, and we're having to use a lot of medical devices or support equipment on them, which is really leading to an increased amount of hospital-acquired pressure injuries. So high reliability organizations are ones that are truly focused on improvement. they really are using this as one of their top indicators and trying to work anything possible to lower the numbers. So a little bit of background on this. The United States spends approximately, and this again was a couple of years ago, but spends approximately $11 billion a year on hospital-acquired pressure injuries. This equates to about $70,000 per case if we're looking at a stage 4. CMS denies reimbursement to facilities if they're stage 3 or stage 4 that were not documented on admission. And again, as busy as staff are at this time, we're finding nurses especially are having a much harder time getting to the documentation or the assessment to say, hey, this person came in with this problem. But if you don't document it within the first 24 hours, it's going to be dinged against the facility. There are also government penalties or where they hold back payments. So really looking at hospital-acquired pressure injuries, not only documenting them, treating them, or preventing them, it really is important that leaders focus on how are staff doing the care and how are we ensuring that we are doing everything possible to reduce the risk that people are going to get pressure injuries. So while facilities are looking at all these hospital-acquired pressure injuries, and even when I took over wound care a couple of years ago, I cover both inpatient and outpatient wound care. We really started talking to the nurses, and of course, the main area of focus is on the back side of the patient, the coccyx and the buttocks, because that's really where they see the majority of them. When we started talking to them and really doing a lot of the research, we found that there were a tremendous amount of medical device-related pressure injuries, in some situations well beyond anything what we expected to see. So a couple of my colleagues and I got together and we said, look, we've got to figure out what are the best practices, what can we do, what are we not doing. So what we did is we pulled all the research publications that we could find over the last 10 years. There was well over 30 solid articles that were published, and we did an in-depth review of them. And when we did this, we pulled it all together and we ended up getting it published in the American Journal of Critical Care back in March of 2020. And it really brought to light, especially to me, since I was the only respiratory therapist on this team, the rest were nurses, how many of the medical device-related pressure injuries were related to respiratory devices. So medical devices and patient care. So many years. I started in healthcare back in 1986, and over the years, I've seen healthcare change so dramatically, and we're now using more devices on our patients, not only to monitor them physiologically, but also for treatments, for keeping limbs from moving, for keeping when they're having significant trauma, orthopedic issues. So we've really changed tremendously over the decades about how many devices we have on patients. So many of these devices are made out of harder materials. They're either rigid plastic or they're heavy foams or things that put pressure on the patient's skin or may lead to friction or movement underneath underlying tissues, and they can put tremendous stress on them. So one of the cross-section studies that we looked at, where they looked at prevalence data, it showed that patients with medical devices were about 2.4 times more likely to get a hospital-acquired pressure injury compared to a patient without any kind of medical devices attached to it. So what exactly is a medical device-related pressure injury? Well, the literature states that medical device-related pressure injuries are pressure injuries associated with a use of a device applied for diagnostic or therapeutic purpose, wherein the pressure ulcer developed has the same shape or configuration as the device. So in this picture, it shows, on the right, it shows an IV catheter. Just something as simple as that is being pushed against the patient's skin, and it's causing a pressure injury below it similar to the shape of the device. So what were some of the findings when we did all the research? So we looked at a tremendous amount of literature, and one of the biggest things that we saw was this large international study where they had almost 118,000 patients and well over 1,000 facilities, and they found a 10% incident rate of patients getting pressure injuries caused by medical devices. Some of the other published incident rates included anywhere from 3% for critically ill patients, 13% for trauma population. Again, these patients tend to have a lot of orthopedic injuries. 35% of hospitalized patients overall got some sort of pressure injury. And really, the really concerning one is 80 to 90% of premature infants had some level of either hospital-acquired pressure injury or medical device-related pressure injuries. Then comes number 3 on the screen, and this is where it really brought to mind how important respiratory therapists are to get this information out to them and train them how to help prevent them. And that is 26%, the number one caused medical device-related pressure injury, especially across the United States, was the nasal cannula behind the ears. So by far, the most common one was nasal cannulas. Now, when I went out and started talking with nurses, that was the least amount of what they were thinking. They were all thinking that it's going to be somewhere on the back of the heels, the coccyx area. But when we told them, this is what the public literature said, but also what our internal results showed, is that nasal cannulas were the most common cause of medical device-related pressure injuries. I'm just going to stop real quick because I wanted to see there's a couple people that I see, they said they're unable to see the presentation. If this hasn't been cleared up, my recommendation is to log out and log back in. Hopefully that will help you. The 9% were caused by pressure masks. So these are on the facial cheeks, the chin, or the bridge of the nose. And these are most commonly caused by CPAP or BiPAP masks. 7.7 were sequential stockings. 7.5 were endotracheal tubes. A little bit over 5% for nasal prongs. This is at the nostril area. So not only do nasal cannulas cause it commonly behind the ear, but also at the base and the front of the nose. Tracheostomy tubes, especially under the phalanges, nasal gastric tubes, or cervical collars. So right there, 5 of the top 8 most common medical device-related pressure injuries were caused by respiratory devices. But when I reached out to schools through Colorado and asked them, what are you teaching RT students about medical device-related pressure injuries or just pressure injuries in general? And they told me their curriculums were pretty limited. They pretty much talked about the fact that, yes, masks, nasal cannulas, especially CPAP and BiPAP, do cause pressure injuries. You got to follow the protective measures. You need to assess. But there really was no in-depth training related to how to do an assessment and then how to prevent them. So what are our challenges when we looked at it? So when we started doing our review here at our university hospital, we were looking at what are causing these medical device-related pressure injuries while they're hospitalized. Well, the number one thing we found was a lack of standardized skin assessment practices. Now, when I started talking with this big performance improvement team, all the nurse educators started telling me, well, the nurses are fine. They've all been trained in school. They know what they're doing with assessment. So we know the old saying, trust but verify. So I went out with one of our clinical nurse specialists and we started asking nurses. And we went from experienced nurses to new grads. We started asking them, how do you do your skin assessment? How were you trained? And we found a variation that went all over the place. So one of the first things we realized is don't believe that all RNs are educated exactly the same way and do the same assessments. So that was one of our big findings. The other thing is higher acuity patients were more likely to have more medical devices and they're more likely to have more pressure injuries or injuries from those devices. And while stage 1 or stage 2 are more common, medical device related pressure injuries may not be identified until they're already a stage 3 or stage 4, which you can see in these pretty significant photos that are in the bottom of the screen is BiPAP, because some of our masks are right on the bridge of the nose, there's very minimal subcutaneous tissue between that and the cartilage. So it's very easy to put that pressure sore right on straight through, which is going to be a stage 3 or stage 4 or unstageable event. And it could have significant impact on your patient if they literally survive and then also they have their gigantic hole through the top of their nose. So this was really important finding. The other thing we found is that hospitals with wound care nurses, they're usually spread very thin throughout the hospitals. There's just not enough of them. And while wound care nurses really are great to have to help with proactive prevention. They really are overburdened with the amount of care they have to treat on acute care and intensive care units. So the nurses are not capable of doing enough of the prevention. It really takes the bedside clinicians to do this. So what were some of the recommendations or best practices that we saw from the research? Well, out of the 30 some studies we looked at, we found 8 that we felt were really good, solid studies. One was a case series, one was a quasi-experimental, 3 were randomized controlled trials, and 1 was an expert opinion by Dr. Joyce Black with tremendous knowledge about pressure injuries. Since medical device-related pressure injuries, they develop faster than normal pressure injuries. So meaning that it doesn't take as long on most patients for medical device-related pressure injury to occur compared to a regular HAPI. So it's really important that we proactively do preventative measures from the very beginning. What I've seen over the years as we started really bringing in BiPAP and CPAP into the acute care setting, and it's grown so much over the decades, is that we used to put protective measures after we notice redness. And what we try to really tell people is you've got to be proactive and do it from the very beginning. Do not wait until there's any issues because the risk is so high, especially on the front of the face. Other things that we noticed in the literature is there's no unique risk factors that were identified that made any patient greater. I mean, we can have a very young patient, and we've all seen this with COVID patients. They come in and they're in their 30s. You slap BiPAP on their face. They are so hypoxic that you can't take the mask off like we normally would with, let's say, a congestive heart failure patient, where we'd take it off for a little while, put them on either a heated high flow or a standard rigid wall high flow cannula, allow them to eat and have a break on their face. The COVID patients, some of them, we can't even do that. They're so unstable. So that risk of that pressure across the bridge of their nose is so high that we really have to be careful. Other things is that it can cause a lot of unrelieved pressure or edema and friction sharing around the patient. So patients that have impaired sensation, they're sedated, they have altered mental status, poor circulation due to diabetes or other health problems. This really impacts the chance that a patient will have a medical device-related pressure injury. So what are the recommendations? Well, one of the biggest one is medical devices should be selected on the basis of their ability to induce the least amount of damage. So when I say that is respiratory, since so many of the pressure injuries that we're seeing are related to our devices, it is essential that respiratory leadership or decision makers for purchasing really select best products. So looking for softer materials, better designs that don't put the pressure in key areas. It's really important that the leaders think about that. So I always tell people is you can say our hospital uses the softest silicone cannulas available. Well, that's great, and that's the way it should be. The problem with it is patients come in, especially where we're located. I'm here in Colorado Springs. We're extremely high altitude in Colorado. So a tremendous amount of our patients come in with home oxygen, or they come in with an ambulance and they're bringing in an external cannula. So what we find is that these hard, lower quality cannulas sneak into the organization. So we've had to spend a lot of time training our frontline staff, especially the nurses, because as we know, not every patient on oxygen is seen by a respiratory therapist. Especially here at altitude, we have tremendous amount of patients that we don't see unless they're on 6 liters or greater. So we've had to train the nurses to really start looking immediately when they come into the emergency room and start feeling that material and saying, is that cannula hard? And then switching it out immediately to a soft one. Well, the same thing would be for buying CPAP masks. How are our pulse oximeters designed, the probes designed? All these things that we use, we have to make sure that we're buying the good quality softer materials, and sometimes that's more expensive, but it's better in the long run because we'll save money on the penalties from CMS, the lack of reimbursement, or the lawsuits, or the damage we cause to patients. And really that is our true goal, is how do we prevent the damage to our patients? Making sure devices are correctly sized. We had a problem with also in a quick break out of having pressure on patients' heels. And what we did is we found out that our materials management team had to substitute a different heel protection thing, and it wasn't the right size for the average patient. So it ended up causing a pressure injury instead of preventing it. So what I always say is RT leaders, make sure your materials management people tell you anytime they have to substitute a product. We try to work very hard with them ahead of time and say, if our primary A is not available, B or C are the only ones that we're comfortable with. If you have to get beyond that, we really need to know. Okay. And the other one that's really important is medical devices should be removed as soon as possible. So having a daily checklist while you're doing quality rounding to make sure, does that patient still need that medical device on them, or can it be removed as soon as possible? Other things were, how often should you do skin assessments? So the literature states really the skin should be assessed at least every 12 hours. And my big thing is, if you have higher risk patients, COVID patients are a great example, or patients that are really high risk, high acuity, have a lot of fluid shifting or localized edema, you really need to start doing it much more often. It might be a very quick assessment every 4 hours with a full assessment done every 12 hours. But it's really important that as much as possible, we ensure that that thorough assessment is done. So when I talk about people with fluid shifts, one of the things is we come in and you put a tracheostomy ties on the patient around the neck, and the patient's really overloaded with fluids. And then you come in, or you come in, check it, it looks great, but over the next 3-4 hours, that patient holds a ton of fluid, and all of a sudden that neck tie is really tight and cutting into the back of their neck. So that's why we really talk to the staff about, hey, when you're going in and doing your assessment, you've got to check every single time, especially with these patients that have high levels of fluid shifts. One, are they gaining weight and the device is getting too tight on them? Or is it the opposite? That you diuresed them so much and now all of a sudden that thing is loose and that trache's going to come out. So it's, again, just doing good, solid assessments. We talk about lifting, repositioning, moving to make sure that there's not pressure put on one area for long periods of time. Make sure that things aren't moving around where they can do shear force friction on the patient. Other things like sequential stockings are things that are really covering a person's skin where you can't see underneath them, is to try and remove them every 4 hours and get a good assessment. And one of the things that we've noticed since we're a level 1 trauma center is we've had to work very closely with the physicians, especially the orthopedic surgeons. Sometimes they put things on patients and they say, nurses, don't touch it. They'll even put a specific order in, do not remove splint. Well, then we've had to work with the physicians and their advanced practice providers so that they are the ones that come in and do take that off, do the assessment on a regular basis so that we don't get a pressure injury. I always tell them, if you're not comfortable with others taking that off so we can look, you have to be responsible to make sure, because we can't go a day or 2 or 3 days without assessing that patient's skin when there's a medical device on it. So again, devices that have tubings, you should always look to make sure that the patient doesn't have it underneath them. There's not pressure from a urinary tube, rectal tubes, art lines, anything where they're being pressed against the skin over time. Other preventative measures, there was very good solid evidence that shows protective dressings need to be in place and help cushion the device. When we were doing some of our original investigation or studies with the performance improvement, we had made a recent change in the tracheostomy tube that we were using with our trauma docs and our high-level oncology ENTs. When they did that, the way the flange was designed, it went from a pretty smooth kind of shape to it to where it had a true like smiley face shape. And when it was sutured in place, when it was fresh, that smiley face was digging into the patient's neck and literally causing a pressure injury. So we had to work with our surgeons to say, look, in the OR or at the bedside when you're doing a perc trach, we need to make sure right while you're putting it in that we put that protective dressing in place underneath, and then you suture it in place with enough movement to keep it secure, but enough movement that we can easily pull out the bandages and keep them clean, dry, and be able to assess the skin. Since doing that, because I'll be honest, when it first happened, the doctors were like, should we change back to our old trach? And I said, whoa, don't jump to that conclusion. Slow down and let's see, can we do a preventative measure that can help prevent that? And when we changed the way the practice was, immediately things got better. So that's why it's so important. So I got a question about pulse ox probes, sensors, and cables, so I will get to that. Going to the next one. Okay, so other preventative measures. So non-invasive masks, since they are truly one of the highest risk, it's making sure that you have the right protective bandages underneath them. So hydrocolloid, these acid gauzes, transparent dressings are really nice if you can use them, because then you can see the skin. There are several different models. I just had a couple on there. I didn't put any brand names, but there are a couple different models out there that help to put the protection where the mask sits on the patient's face, especially around the nose, but also moving around the different types of masks, which many of you know, but the full face scuba type mask compared to the standard one across the bridge of the nose. And now there's some wonderful products out there that go underneath the nose. So having options, and not all work with every patient, but having options to change. So routinely every 4 hours, switch to different masks so that you take the pressure off the different areas. So very important to make sure protective measures are in place, the protective dressings, change where the pressure is located by changing the mask design and type, and really keeping a close eye looking at the patients. That's the biggest thing is, are we seeing any risk of discoloration, any signs of redness, things that might tell us that we've got pressure? And it does not take long. 2 to 4 hours of direct pressure can be enough to cause the patient to get a pressure injury. This is probably one that everyone across the country, there's almost 700 of you on this call, are dealing with, and that is proning patients. I remember that just 2.5 years ago when we proned a patient, it was a big deal. Now we prone so many patients, it's just a regular daily activity. The problem with it is we've got to make sure that our teams slow down when they're putting the patients in these swimming positions and their faces are down for such long periods of time, is to make sure that they've assessed and checked to make sure there are no cables, no pulse ox probes, no nasal gastric tubes, the endotracheal tubes. Nothing is being pushed back or forced against that patient's face or skin anywhere on the body. And that is essential, because this is where these patients are staying 12, 16, 17, 18 hours face down. We're just not humanly designed to be on our faces or on the front of our bodies, so we're more prone to break down. So I just tell everybody, slow down, double check, make sure all the lines are clear. It's just so important. Considerations, especially when you're talking to materials management, they are money driven, and they should be, because they do need to save organizations. But save organizations money is to make sure they understand inexpensive or cheap materials could more likely lead to pressure injuries that are hospital acquired, which in turn is going to cause as tremendous cost to the organization. So spending a little bit more up front will save you money. And sometimes you have to do a cost analysis by working with your quality, risk management, or patient safety teams to say, how many risk events or pressure injuries have we had in the organization related to these devices? What is the estimated cost of the care? And then you can go back and talk to your leaders and say, hey, if we go to this more expensive cannula, sure, it's going to cost us 20, 30, 40,000 more a year, but we're probably saving, 200,000 or 300,000 in other costs related to pressure injuries. So always work with them. The other things we've done is we've reached out to the EMS and DME companies and tried to find the companies that are willing to spend the extra money and have better quality cannulas for their patients. When I was practicing in San Diego, we might send one patient home a day on home oxygen, maybe two. Here in Colorado, we'll send 10 to 15 home a day on home oxygen. So really working with them to understand the importance of the high quality cannulas is important to get across to everybody. So let's talk a little bit about performance improvement projects and how you can hopefully reduce the risk of pressure injuries at your facility. So this right here is an A3. It's a tool that you can use for performance improvement. Our hospital likes to use these. It's a single sheet that gives you the overview of the reason for the action, what's a synopsis of the gap analysis. What is our plans and how are they being completed on a timeline? What's our current state? What's our solution approach? What are we testing or trialing? And then what's our confirmed state after we make the changes? So I've always had a rule of thumb. I was a patient safety officer and risk director for 6 years. So I spent a lot of time doing performance improvement. And one of the things I learned when I attended the patient safety movement, one of the annual conferences, is they always talked about a process of one physician, one patient, one nurse, one RT. Test something first in a small scale. Once you get through the big hiccups, then do a smaller set of scale and maybe one unit where you'll test the amount of patients. Work out all the kinks before you keep expanding it to other units. One of the key things about that is every single unit in the hospital has its own risk. So orthopedic units are more likely to have falls, more likely to have pressure injuries. Renal units may be more likely to get central line infections or urinary tract infections. So there's things that are very specific to the unit. So when you work with quality and patient safety or risk, you can find out where are your biggest events occurring and where should you start your pilot project. This is another tool, and this is what we call the 3, 4, 5 whys of what's gone wrong. So it's asking over and over again, why are we having the problem? So defining the problem in this situation, there were several variations in practice on each different acute care unit related to doing a head-to-toe assessment. Again, like I said earlier, when we went and started talking to the nurses, it was all over the board on how they did their head-to-toe assessments. It could be related to the different nursing schools they went or practices they picked up during orientation, but there was too much variability. So first why is there's no consistency in the nursing process for a head-to-toe assessment or during a transfer of trust. So we do a gap analysis of why. So then the next question is, why is there no standardized, repeatable process for nursing to conduct a head-to-toe assessment? And again, then you do a gap analysis. And then why, again, why is each unit has its own culture and how they do it? And then why did this happen? Well, the different people that were in charge of acute care put together a process years ago, but they didn't make it standardized and repeatable. So this tool is really nice for you to work your way through on how do you get through each issue that's leading to your problem or your root causes. Another thing we try to use is as much data as possible. So this is just some examples of where you can show the different things that are causing pressure injuries. So this example shows it's pretty straight across the board. Some are oxygen tubing, some are on trachs, some are caused by TED hose, rectal tubes, across the board. So when you break down even more detail, this allows us to show that what the national statistic shows is that nasal cannulas are the #1 cause of pressure injuries. But a lot of times they're even missed because nurses aren't even assessing behind the ears. So unless the patient complains of pain, they may never even see it. But this showed that the Pareto chart clearly showed the ear was the most common pressure injury that would happen in a hospital. Second was the buttocks, thoracic area, the heels, then the nose, nasal, and the septum, and that's caused again by the nasal cannula. You can see the lip, most likely caused by an endotracheal tube securing device, and so forth. But by showing this data, it tells you, well, what do we need to focus on? What would be the best bang for our effort? This one shows, of those pressure injuries on those body parts, what was causing the pressure injury. So again, oxygen tubing was the #1 cause, and that's when we started doing rounds looking for the hard tubing in the nursing areas. And it took a lot of repetitive education to the nurses over and over again. It still is happening that you've got to check the cannula when you're assessing your patient. So when you're talking to them, you're looking at their face, you have to fold the ear over and look at the back of it. And while you're there, touch that part of the tubing that touches the ear and make sure that it's soft. Even the soft silicone cannulas over time will harden. So when in doubt, throw it out and replace it is what we taught people. But this showed us endotracheal tubes were still an area, oxymasks were, and the oxymask, one of the things we found, the mask was great. the issue was when you take it out of the package, the elastic strap was tight and you had to pull it out to get it over the patient's head. Well, that caused some people just barely to pull it. They would just stretch over the patient's head, and immediately you'd look straight at the patient and their ears are being pulled down, and they almost look like they're on Star Wars or some weird creature thing. So we have to get people to understand you have to loosen those straps up to make sure the ears are not being pulled down. And then we wrap protective measures around the strap, not on the patient, and that gave us better protection from that area injuring the patient's ears. We put together a tremendous amount of educational material where it showed people exactly how to pad the areas that are more likely to cause injuries. And depending on your brand of securing device for your endotracheal tube, there's different shapes of them, but some of them put pressure right over that front of the face, both between the bottom of the nose and the upper lip. And it's really important that you pad that correctly and that you don't tighten down the holding device too tight because it can shut off blood. We also put on there who can do this or who should be putting the protective measures. So in this case, it could be the RN or RTs, because our entire training program was designed to have the RNs and RTs trained in the exact same way to do an assessment. Both do it during their shift, and then they get together at least once per shift and talk about what their findings or concerns are. We do promote that, if possible, that they do it together. So you have two clinicians looking at the patient together, but realistically, that's not always capable because we all know how crazy busy we all are. But we ask them, you need to make sure you do your assessment and then speak to your counterpart in the nursing world and talk about any areas of concerns. And it really has helped improve the amount of people doing assessments. Another example to consider, like I said, the design of some of the holding devices puts that pressure, and it's padded right there in the upper part of the lip and below the nose. It's padded to protect from pressure injuries, but if you snug it too tight, it pushes on the face and it shuts off blood circulation, and you can't really see it easily, and people can get the problem. And I have a picture on the next slide that shows what the outcome can be. The other one is bite blocks or not moving that tube around enough. And this picture here was included in our published article. This is one of my colleagues, her mother-in-law, who was intubated, not at our facility, another facility on the East Coast, and they didn't move the endotracheal tube around enough, and it had a bite block, and it literally left this horrific injury to her tongue. This next picture shows you, these are two different individuals, but both of them had large upper lips and a lot of facial swelling, which caused, when they put the securing device, it put pressure between the bottom of the nose and the upper lip, and when they secured it, it was causing the blood to be shut off. And I've seen it more in patients that have what I would call more of a snaggle tooth, where the teeth are turned or moved. It puts more pressure on that, cuts off the blood circulation. So one of the things we tell people is make sure it's secure but not tight. Lift that lip up as best you can. Look underneath and look that you're getting good blood flow. It is so important to have good blood flow. Otherwise, these injuries can be traumatic. Additional education materials, again, showing where you can pull or put the pads below the neck with trach securing or endotracheal securing. Those are areas in the back of some people's necks that can get some significant pressure injuries. This one, again, showing different ways to pad the septum and protect them. But all these are just designing simple educational material, and you can do it with whatever brand of protective measures you use. And get them out and really get them out in front of the staff. Post them on break room walls, put them in the restroom if you have to, whatever it takes to get people to really keep thinking about it. It's getting them to think about it. Here's another thing that we use to train patients. It's called a skin bundle, and it talks about the different things you have to do for the skin surface, keep things moving, how to adjust things. Is the patient got incontinence that's leading to their nutrition? But again, it's just what are the considerations that a nurse should do? And a lot of it is good for the therapist also to look at, because some of the stuff will cross over into our profession and area. We built prevention models where we literally did algorithms that showed when you're doing the risk assessment, did it show the patient at risk or not at risk? What should you do? Breaking it down for everything, nutrition, skin care, safe transfers, what medications we should use, when to call wound care, when not to call wound care, when to call wound care a second time because they had one pressure injury and it was starting to get better, but let's say it got worse. So there was very specific things that we used to try to get our staff to know when to do things or when to call. Again, process mapping. All these things can really help you because then you'll find your weakest links and you'll figure out ways to tell your staff or educate your staff on what steps they should take. These are all simple. They're not and once we go over it once with the people, they don't even need to look anymore. They just know what to do. This next slide, this one talked about when we were getting ready to do our research project where we were doing the RN and RT shared responsibility of assessment and preventative measures. We really wanted to get as much data. And this is where frontline staff are so important when you're doing a performance improvement project. One of our clinical nurse specialists, brilliant brain. I mean, I wish I had a brain. She's so brilliant. She put together this detailed thing and said, okay, listen, you don't have to check every single thing. You just look for the device that your patient has and just focus on that section. Well, when we put this out the first few days, the staff were already so overwhelmed with COVID that when they saw this, it just overwhelmed them. It just freaked them out. So we had to talk with them. What's working? What doesn't work? What's delaying you or what's stopping you from getting data or doing things? And this was one of the things that really drove them crazy. So we just converted it to a simple per shift checklist that said, did you complete your full assessment? And did you speak to your counterpart, respiratory or nursing? And was wound care consulted? It was just check mark, check mark, check mark. And that's all we needed to know. Did we get better assessments? Did we have the colleagues talking to each other? And we did truly see a tremendous decrease in the amount of happies that were predicted especially with COVID going on. Next thing is one of the RTs that works with me. She was doing her career ladder project. So she took the article that we published and she just took it and made a really cool poster that showed people the most common respiratory related devices that cause pressure injuries and what the best practices were, and made these beautiful big posters we laminated, and those went into the break rooms and we used them for teaching. But again, it's just to remind people, get it in front of their face, get them to be thinking about it as much as possible. Because again, RTs are not trained in RT school heavily on skin assessment or even on a lot about preventative measures. And hopefully that will be something that changes in the future. But for now, it's going to be hospital by hospital that we need to do that kind of education. So summary, I guess I wanted to go back because one of the people had asked about pulse oximeter probes. So we've noticed a lot of issues, especially with our COVID patients. So what I recommend is you work with your manufacturer. So what we did is we reached out to the company that we use, and I can say they were tremendous. We got on immediate calls. They put on their best practices. They gave us a lot of ideas of what we could do to change. One of the things that we've done with a lot of patients, because we're proning, is you're doing ear probes. Well, people would put the ear probes on the part of the ear that has more of the cartilage, and that's a problem. If you do that, there's a higher risk of getting a pressure injury. So it's making sure that it's on the lobe or the softer tissue, and it has to be moved frequently. And you really got to make sure you don't forget it if you're turning that patient while prone and they're leaning on one side of their head. But we have to switch them fairly often because a lot of these patients are so critically ill that they're shut down. So they're not getting as good circulation, especially to their hands or other parts where they were monitoring with the probes. So you may have to say, okay, our normal process is we change them every 8 hours. Well, maybe with COVID patients, you need to change the location every 4 hours. Okay, and make sure that that poor cable that goes off away from the probe didn't accidentally get anywhere underneath the patient, because those are things that we do see. So summary, hospital-acquired pressure injuries definitely remain a significant challenge. And like I said, this presentation was put together prior to COVID. COVID has just exacerbated that problem, made it worse. Medical device related injuries need to be a focus area. So every hospital, I really believe, need to focus on this. And since respiratory devices really cause a lot of these, I think respiratory leaders need to step up if they haven't already. I'm sure many have, but step up and go work with your quality people and help tell them the value of respiratory therapists. If your hospital is not using respiratory therapists as a co-clinician to look at these patients and do a heavy, solid assessments and preventive measures, I really recommend you do that. It's to show the value of therapists and why we're here. Proactively train your staff on consistently doing their assessments and their preventative measures from the very beginning. Don't wait till there's a problem. And again, not all products are designed the same. So really focus on getting the best quality software products and reach out to your manufacturers. When we were doing a system-wide go live with one of our new monitoring systems, the manufacturer we worked with, they had subcontracted out a cannula and then brought in another one, and it wasn't as soft. Well, we reached out to them, and they're very receptive. And they spent pretty close to a year working with us and we helped them redesign their cannula. So not only are they safely monitoring their patients for like respiratory depression, but at the same time, that company gets to promote the fact that their cannula design is also built to help reduce pressure injuries, which is another form of hospital-acquired harm. So work with them, let them know. And one of the reasons why I say that is when we reached out to them and said something about the cannula being hard, they said, well, we've never had a complaint sent to us before. And I think it's because many hospitals, when they get a pressure injury, they think it's their fault because their staff didn't do something. Well, there may be a contributing factor by the product. So we have to talk with our manufacturers. I don't want to beat them up or anything, but I want to work with them and get them to build better products that are safer for our patients. So please speak up, let them know when products are contributing to harm so that they know to help work with you on better products. Here's some of the reference material that I used. We do a lot of research on this, and we're continuing to do it. It is one of my areas of passion. So I really ask you, if anyone's interested or have great ideas, please let me know, reach out to me. I'd love to learn from you. And that's it. Do we have any questions? And the gentleman on the picture next to me, that's Dr. Peter Pronovost. He's one of the godfathers of high quality patient safety, and that's at the patient safety movement. He truly was one of my champions and heroes when I started working in patient safety. Brilliant mind. So I always like to give a shout out to him. So now we're going to go to questions.
So Kevin, I'm happy to read questions for you. The first question, is there a correlation between pressure injuries and obesity?
We did see some in the literature, and what we found is sometimes it's the lack of mobility or movement and the microclimate of the skin. So heavier amounts of moisture in folds or areas around, or devices getting underneath the human body areas. And that's where people didn't see them. The patient rolled over in bed and they're laying on top of a catheter, or they're laying on top of the pulse oximeter probe. And we all know that when you click the pulse oximeter probe part into the cable, that lovely little area where it connects, that can easily get below a patient, but that itself can cause a tremendous pressure injury. So we did see some areas where obesity led to it. Sometimes it was just harder to turn them or move them, or if they were less active. So I would say, yes, we did see some significant changes on those patients.
Great. What is your hospital's protocol on using full face mask with BiPAP or CPAP? And second part, what do you use for prevention of pressure injuries with these types of masks?
Okay, so we use masks that are the ones across the nose, the more common ones. Then we use the full gigantic face scuba mask, as I like to call it. And sometimes with the high levels of pressure that we're having to use especially with COVID patients, the patients don't like those. It's blowing too much pressure into their eyes. So it's working with what the patient can tolerate. And just recently, we have brought on board the ones that are designed to go underneath the nose and into the nostrils. And patients may say, I can't tolerate it for 12 hours, but they may say, okay, I can tolerate switching between the masks. So our protocol is the therapists need to switch the mask when they go in and do their assessments, so that we're not causing the pressure in the same area of the face over and over again. So if they're on the across the bridge of the nose mask for 4 hours, then they'd switch onto the full face scuba mask. And then the next time they go around would be the below the nose mask. So it's having those options. And I know in the past we've always said, oh my gosh, that's expensive. But the reality is you're seeing so many pressure injuries with these high acuity patients. The cost easily is outweighed by the benefit of the patient.
Yeah, good point. Another question, what is everyone utilizing to prone COVID-19 patients and avoid extubation with tape? We utilize Hollister still and continue to have pressure injuries. Would you recommend something such as Duoderm underneath the Hollister? And then we additionally utilize Z-Flow Positioner.
Okay, so what I recommend is that you assess your options. At our facility, we use Hollister and some of the other devices that are similar. But when we go to prone the patients, we go to a manufactured tape design. So we switch them off, put them on that tape so there's no hard plastic on their face. And then we switch them back to it. And that is a lot of work, but the risk of pressure injuries is so high. If you're using any brand of securing device, especially ones with a mouth guard, the bite block, you've got to make sure that you really have a well-designed system. Some hospitals have decided to no longer allow bite blocks because they've caused so many pressure injuries, and some of them are catastrophically significant injuries. My philosophy, if you have to use a bite block, use it only when you have to use it. When the patient is actively biting and fighting, but once they can medicate the patient, get them to where they're not biting and you feel safe with that, you've got to get that bite block portion out of their mouth and do better assessments with them. So I'd say for anyone, if you're using a rigid designed securing device, you have to decide if that's the safest thing, because we see significant injuries, especially if you're pushing on that patient's face where the two discs are that go across the cheeks. You can get ones that literally, when you take the pad off afterwards, it takes portions of the patient's face off. And that's definitely not anyone's desire.
For sure. So one question was, I don't see a CPAP mask on the chart of what devices cause pressure sores. So would you have any comments on CPAP specific masks versus, and I'm assuming that could be nasal as well.
Right. That, again, any device that goes on a patient can cause a pressure injury. So we have to look at the designs and how they fit the patient's face. Now, we use limited numbers in hospitals, and this is why some hospitals, it's always up to the hospital, but some hospitals have decided the risk-benefit ratio means patients should bring in their own home units with their own nasal interfaces, because patients wear what's comfortable compared to what we have to use. So it is just looking at the cannula, the interface, the design. Where is it pushing pressure? Is there things you can do? You can use Mepilex on some patients. You can use non-petroleum chapstick even. Don't use petroleum, we all know. But you can use this simple stuff. I would just say really work with your wound care people to assess the devices with you and what preventative measures you can use to help reduce the risk.
Great. Somebody asked about Aquagel dressing for padding. I guess, obviously we're using it for proning, but can you use it for other padding?
Again, my recommendation is work with your wound care team, because they're the specialists, and what type of dressings are the best for certain areas of the body. And because you don't want to pad an area but causes a microclimate change of causing too much moisture, which then could cause a problem. So work with them, and we've used many different preventative measure pads. But we always go to the experts in wound care nurses and have them work with us when we're assessing them for the good, the bad, and the ugly of everything that we do. So that would be my recommendation. We use the beautiful clear gel pads for our patients, and they are costly, but they do help prevent a lot of patients from getting pressure injuries. And there are sometimes that different patients, we can't use that kind. We have to use foam ones. So it's learning with wound care what is meant for different types of patients or what's available, because we all know with COVID, we get stockouts, and we just have to learn what are our options to use.
So this is actually a really good question. I have a COVID patient on long-term heated high-flow nasal cannula that has developed a severe rash on the upper lip. Unable to wean cannula, what can I do to help her?
Yeah, that's a tricky one because it could be their body having hypersensitivity to the rubber material. I mean, it's usually not a latex thing, but just the rubber material itself can be causing the patient to have that. It could also be so much moisture. Again, I tell the staff, we're using levels of heated high flow that we've never used before and for such long, prolonged time frames. So it's changing that microclimate and causing so much moisture on the upper lip. So again, I'd work with the wound care nurses to say, is there any product that we can put safely across that part of the face that will help start being a barrier to prevent that moisture from causing the skin to weaken or blister? And there are certain products you can use and certain ones, again, because they may be petroleum-based, that you can't use because of all the oxygen. So work with them to find which one is safest for your patient, because like I said, Ventilex is a great one, but it can't be used with high levels of oxygen at all times. So you just have to learn your ways around it.
Fantastic. Kevin, there were a couple questions that related to access to your presentation. And, you know, obviously, if you're happy to release that, we don't actually distribute those, but we're happy to if you have anything to add to that, if you're or want to share anything.
Yeah, I'm totally willing to share. The only thing I say is if you're I can send one that doesn't have the UC Health specific stuff that we've done, which is only a few of the slides. I have a didactic version, and then we can hand it out, or anyone can reach out to me. It's pretty straightforward. I'm very happy to share anything.
Fantastic. Well, listen, thank you again for Kevin for joining us. Amazing presentation, and thanks for your work. Also, thanks to all who attended. We hit over 700, which is amazing. Thank you all for taking an hour of your time. As Kevin said, I'll reiterate, we know you're busy, and you spend your time with us, and that means a lot to us. So thank you for that. A couple announcements. Please join us on October 15th for the next broadcast. This will be our October 2021 Respiratory Care Journal cast with Philippe Demani. Exciting about that. Great article he's going to assess with that. Also, for Respiratory Care Week, we're going to have a very special Respiratory Care Week presentation on the transition from acute care to home care. We'll have two presenters, Becky Anderson and Tim Buckley, and Patrick Dunn will moderate that. So we're very excited about that. Once again, thank you all so much for spending an hour with us. We really appreciate you and all you're doing, and that you take your time out of your day to spend time with us. And have a great day. Thanks again, Kevin.
Thank you very much.
Thanks, Lenny. Just as a reminder, if you are a group participant, please have your group leader submit your information to the group attendance tab to be provided with follow-up instructions on how to submit for credit. If you have any questions, please email crce@aarc.org. This does conclude today's presentation. To submit for credit, please click on the Credit Submission tab. Once you are finished, you may simply exit out of your browser window. We all hope you have a great afternoon.